Well, good morning, everyone. Welcome to our Epidemiology and Community Health seminar series for the fall. We are nearing its end. I can't believe it. So in addition to today's seminar, we will have two remaining for the semester. Next week, we'll have one of our newest faculty members, Sanaz Sidiga, speak to us about her work. And then the following Friday, we'll have someone come speak to us about imposter syndrome and how it affects the workplace and academia. So I'm really excited for how we are ending this semester. My apologies for those of you who I haven't met before. I need to introduce myself. My name is Ruby Nguyen. I'm an associate professor here in epidemiology. So today is a good day. If you've been following us on Twitter, we've been having a little bit of fun with today's seminar. One of the huge disadvantages of this seminar series is that during the pandemic is that we can't have our friends come and visit us and meet the rest of our faculty and our trainees and all of the great people working alongside us. And I think that's been a huge disadvantage for everyone. However, today we're so happy that one of our friends from out east, from Boston University, is able to come visit us in this way. So I'm going to ask Dr. Rachel Whittam to give the proper introduction, but I do want to say also that Dr. Murray will be joining us for an informal session for about an hour and a half after the seminar. We have some trainees coming in and some faculty coming in to visit using the same Zoom link, but we are inviting you as well. So if you can stay over a little bit, please feel free to. If you want to leave and come back, you can do that as well. So I hope to see you there as well. So Dr. Rachel Whittam is an associate professor in the Division of Epidemiology and Community Health, and she will be taking it away from here. Thanks, Rach.
Thank you so much, Ruby. So I think the past 2 years have really illustrated to all of us that epidemiology is not easy. And it gets especially challenging when we're doing work that's going to guide choices that impact large numbers of people, either as far as policy goes or in the realm of patient care. So our speaker today has focused her career on honing and developing methods that can provide clearer and more actionable answers. She's developed ways that help us lift the cloud of uncertainty that shroud all of our messy data situations. You might already know her a bit from her presence on Twitter, her very frequent quotes in national publications like the New York Times and the Atlantic, and her steadfast work throughout the pandemic to communicate issues around COVID, vaccination, and epidemiology to the public. Dr. Murray's on faculty in the Department of Epidemiology at Boston University, and prior to that, she did her doctoral and postdoctoral training at Harvard. She also holds a master's degree from Columbia University. She's the social media editor of American Journal of Epidemiology, and she has a great podcast named Causal Inference. She's one of those people that always has a lot of things going on, seemingly building new collaborations at every turn. But in the midst of all of that, I've been so impressed with her dedication to students, trainees, people new to the field, and kindness to people in general who are just epi-curious. I want to say here that she's one of the truly wonderful people in our field. She's also one of the few people that I know that has drawn a portrait of our proud Division of Epidemiology and Community Health building, the WBUB. And so with this, I'm absolutely thrilled to introduce my friend and colleague, Dr. Ellie Murray. Thank you, Ellie.
Thank you so much, Rachel. Let me share my slides here. Okay, I hope you can all see that. So I just want to say, yeah, thank you so much for that introduction. Like make me blush a bit. I also want to let everyone who's in the audience know that I'll be including some more of this recording of this talk on our upcoming episode of Causal Inference. So you can always kind of catch pieces again there. So today I want to talk about kind of this big picture overarching sort of scheme of, oh, I shared the speaker view. Thank you. All right, let me try that again. I think I have to close this here. Yeah. All right, let's try that again. Thank you. Now, do you see the presentation?
Yes, we do. Thank you.
Perfect. Thank you so much. Okay, great. So today I want to talk about kind of the overarching theme of what I work on across all the different collaborations I do. And this is the idea of how do we ask questions that really matter and get answers that help us when we want to improve public health. And this kind of all ends up falling under the idea of causal inference for complex data. So first of all, what are we even trying to do here? So I always like to kind of come back to this idea of epidemiology as, not just, it's definitely part of, understanding the distribution and determinants of disease in terms of learning who has which health problems where, but it's also about figuring out what to do to change that. So using our knowledge, applying our knowledge to make changes to public health. And when we think about epidemiology like this, we really see that the whole mission of epidemiology is really about knowing that we have to ask the right kind of questions that help us and estimate useful answers that will help us actually make those changes in ways that move the health of populations forward. We also see that when we start thinking about it like that we can't make changes in a positive way to the public's health unless we understand and can estimate causal effects. And so to my mind, everything we're doing in epidemiology has this underlying framework of thinking about causal relationships and thinking about causal effects, even when we want to do just descriptive epi to really understand that first piece of who has which problems where, which is definitely important and is something I've been thinking a lot more about, but we still need to kind of think about how does that inform the various types of things we might want to do to make changes and improve people's health. So that brings us to the obvious question, how do we estimate causal effects? And so the punchline of this talk is what I like to attribute to Miguel Hernan, my PhD advisor, has a two-step causal algorithm that is everything you need to know about estimating causal effects. Step 1, ask a good question. Step 2, answer that question with appropriate methods. So that's the take-home message of everything I try to do. But obviously, it's not really that simple. We have to really understand what each of those pieces are. So I first want to talk about how we ask good questions. And in the context of causal inference, a good question is something that's a clear causal question. So what exactly is the exposure or exposures of interest that we want to study? What exactly is the comparison group we want to compare it to? What exactly is the outcome we're interested in? And who exactly do we want to talk about? And these 4 questions will really help guide us with structuring our question. It's also important to remember that, relationships of every kind are complicated, but in epi, they get really complicated really fast. Treatment confounder feedback is one of those complications, and I'll talk about that in a minute. But even just defining what we mean by our exposure can be really hard. So for example, if we're thinking about psychiatric epidemiology, and maybe we want to study the role of post-traumatic stress and depression on suicide among individuals who've experienced trauma, should we be thinking about post-traumatic stress and depression following trauma as 2 pieces of the same exposure variable? Should we be thinking about the separate components that make up post-traumatic stress as 3 separate exposures? So re-experiencing, avoiding, hyperarousal. How do we really want to conceptualize that exposure? And that can be really hard. And how we decide to conceptualize that can have really important implications on the questions that we ask. And then even worse, even once we've decided how we're going to conceptualize that, we may not be able to measure it in a way that's easy and in a way that gives us a clear answer. So, there's some actual sort of truth about somebody's depression status, but all we have in our data is the measurement that we've made of depression or the measurement that we've made of PTSD. And even in the case of this example, we could have measurement error in the outcome where reported suicides and actual suicides may not perfectly line up one-to-one. And all of these things add potential for our questions to get more complicated and harder to answer. And so when we have complex exposures, we get complicated answers. And even if we can do a trial, so for example, this little graphic here is displaying a trial that was conducted a couple of years ago, where individuals were assigned to both a diet, which the intervention group was a sort of special type of protein shake, as well as assigned exercise, and they were followed up to see what the weight loss outcome would be. This is a randomized trial, so in theory, we should get a single answer from it, but the intervention has these multiple components. And what we saw is that when this trial was reported in the media exclusively focused on that diet piece. All the headlines were about that this shake is the secret to weight loss. And it didn't even mention that these individuals had also been assigned to an exercise intervention. And so we can see, even in a trial setting where things should be nice and simple, if we have a complex exposure, we need to think carefully about how we analyze that. Do we need all of the parts of the intervention? Does it matter what the timing of the pieces or the ordering of the pieces are? And how would they work against some other type of comparison group? For example, the shake versus a Mediterranean diet might be different from the shake versus a traditional Japanese diet. And the comparison group we use is part of the question that we're asking. So let's take a little step back and ask what makes exposure complex. And the answer is basically everything, but multiple components that make it hard to define and measure. So something like race or socioeconomic position, or even an intervention like cognitive behavioral therapy. The presence of interference between individuals, so transmission of infection, transmission or learning, shared knowledge, shared behaviors, those kinds of things can make an exposure complex. Exposures that vary over space are complex, so something like air pollution, but also access to goods and services. Exposures that vary over time, and this could be something like unhealthy or unhealthy habits, but it can also be medication usage. So if you have to take statins every day, that is a complex exposure. We're not just thinking about take statins once. And then lastly, a simple exposure that might otherwise seem like a pretty clear, easy, not complex exposure could be complex if it could happen at any time. So if we're thinking about an individual with osteoarthritis and what is the effect of surgery on their pain levels over time, the fact that they could have that surgery at any point during their disease progression actually turns it into a complex exposure and not just a simple yes or no on the surgery status. And then, as I said, we have feedback loops, which are really make things really kind of messy to think about. And so this is the idea that the treatment you get might depend on your historic values of your confounder, and that the treatment that you take might then affect future values of that same confounder. But time doesn't actually go in loops. We don't actually go from the present to the future back to the past. And so what we really need to think about with these loops is that they represent a recurring sequence over time. So we have a confounder like viral load at baseline, and then we have that same variable, but measured at a different time point or occurring at a different time point later on in the time sequence. And similarly, we might have treatment at baseline and then treatment after some time period. And these types of exposures and structures are more complicated to estimate causal effects for than when you just have a single time point that you're interested in. But another thing that makes them challenging is thinking about where are we going to cut that loop into a straight line? So what is our starting point? What are we thinking about in terms of the ordering? So should we have cut this loop at trauma and then have PTSD and then treatment and PTSD later? Should we have cut it earlier and had some pre-trauma depression symptoms and possibly pre-trauma treatment for depression? where in that loop do we want to cut it? And that's going to affect the kind of questions that we ask. So this is a sort of chicken and an egg question. And then all of those things are true when we can, even when we can intervene in a trial, but as you know, I'm sure you all know, a lot of times we can't intervene either for ethical, logistic, financial, time constraints, just nobody is interested in intervening. And when we can't intervene, we have to get even more careful about how we're asking these questions. And so this leads us to the idea of framing a well-defined causal question. So why are well-defined causal questions important in terms of what answer are we getting when we ask a well-defined question? So in this particular cartoon, you can imagine that this little figure here has high blood pressure. And the high blood pressure that this individual is experiencing has come about because of some set of factors in this individual's life. And that might be related to diet, it might be related to medication, it might be related to genetics, or it might be related to some combination of those factors. When we have a whole study population of individuals with high blood pressure, the individuals in that study population have some distribution of these causes or interventions that could have happened to them that gave them high blood pressure. So there's some distribution of genetic causes, some distribution of diet causes, some distribution of medication causes, et cetera, in our study population. And so when we have this situation where there's these sort of multiple causal interventions that bring about our exposure of interest, and we don't restrict ourselves to only one of them in asking a question, we can end up in this situation where if we look at the effect of high blood pressure on some other outcome, for example, heart attack risk, even if we can estimate that perfectly, even if we can identify that causal effect, our answer isn't the average treatment effect of high blood pressure on heart attacks. It's the weighted average of all of the ways in which high blood pressure comes about in our population, the weighted average of all of those effects on high blood pressure. And so, you know, in a paper with Alex Breskin, we named this the weighted average causal effect, or the WACE, to kind of highlight that it is a slightly different causal effect that you're getting. Now, sometimes this is really useful for things like high blood pressure or cholesterol or other biomarkers where we can't intervene directly on that biomarker, but we're still interested in asking questions about them. Then the WACE is probably the best that we can really do in terms of a clearly specified intervention effect or causal effect. So it can be useful, but there's a problem. Because the problem is that if all of those different interventions that we have that could have happened to cause the high blood pressure or the high cholesterol in our individuals, if those aren't clearly defined, if we don't know what those are and we don't know what those weights are, it's also really likely that our confounding is ill-defined, because those things themselves happen for a reason. And if any of those reasons are related to our outcome, then that's a potential confounding path that we might not have controlled for. So we can think about the WACE as structuring a causal question when we have a variable that we can't necessarily directly intervene on, but then we have to be really, really careful, both to clarify that this applies to populations with the same distribution of ways that the biomarker came about as the population we're studying. And if we can, you know, contextualize that with some descriptive epi, that's great. But also to be clear that, you know, we really have to believe that we have no confounding and that we have clearly specified the confounding. So one of the ways in which we can kind of frame our thinking to ask a good question for a complex exposure is with the target trial framework. So this is the idea of thinking to yourself, you know, I have a question I want to answer. If I could have done an intervention, if I could have done an experiment, what might that experiment look like? And how would that experiment help me make, or other people, make a treatment or policy decision or a decision about what to do in their lives? And we want to target that to a question that's specific enough that we can get an answer that people could act upon. So I want to go through some examples of what sort of poorly and well-defined causal questions might look like under the target trial framework. So thinking about this idea of what questions lead to actions, we might be interested in knowing something about the influence of gender on poverty. So we could try asking a question like, does gender cause poverty for tipped workers? But if we think about translating that into the counterfactuals that we would be comparing, what that question really ends up being is, what would the difference in total income for all tipped workers be if all tipped workers had been women versus if those exact same tipped workers had instead been men? And that is not really the question that we actually wanted to ask about when we thought about how is gender, is gender playing a causal role in poverty? We don't want to think about the same workers having their gender switched. It doesn't tell us something that we can act upon, and it doesn't really help us understand the situation any better. So another way of framing it, and I apologize, this is a little small because this question gets a little bit longer. And this is one that reframing of the question that is inspired by research by Dr. Sarah Andrea and her colleagues. So we could instead ask, if women in our study who work for tipped wages received the same amount of tips as their male colleagues, would their overall poverty risk decrease? And so now we're asking the causal contrast. What would the difference in total income or in poverty risk be for women who work for tips if all those women received the same amount of tips they usually receive versus if those same women received the amount of tips that their male colleagues typically received? And this is a question that can help us get to the heart of what's going on. We could, for example, plan a policy intervention. Maybe men are getting more tips, and if women receive the amount of tips that men received, then they would be less likely to be in poverty. On the other hand, maybe there's really not that much difference in tips, and that's not where the difference is coming from. And we need to think about the next research question. But this question helps us understand and move forward to a solution for intervening to decrease poverty among individuals who worked for tipped wages. Another example, which is a very recent one, but is something that's talked about a lot. So we see these huge racial disparities in COVID mortality, and that might cause us to ask the question, does race cause death from COVID-19? Again, when we think about the counterfactual contrast there, we end up with this weird question: what would the death rates from COVID-19 be if all of the individuals who became infected had been people of color versus if all those same individuals had been white? I don't know what that question means. I don't know what to do with the answer to that question. There's no way, we have no desire to change people's races, and there's no real way to do it. And this doesn't help us move forward. We can't really act upon the answer to that question. On the other hand, and this is inspired by a recent paper by Dr. Justin Feldman and his colleagues, we could ask a more targeted question that helps us begin to understand what we might need to do. And this more targeted question says, if people of color in America had experienced the same rate of death from COVID-19 as white Americans, how many more people overall would be alive? So now we're asking, what is the difference in deaths from COVID if people of color who were infected had the probability of dying that was actually observed compared to if those same people of color had instead had the probability of dying that was observed among white Americans? And this helps us plan policy interventions. It helps us step forward. We can then start asking a question, well, is the disparity in deaths due to a disparity in infection rates, or is it due to a disparity in what happens to you after you've been infected? And answering that will help us figure out where we need to channel our attentions to most importantly. And so this is a way we can still answer these really big, important social questions, but hone in on a clear causal effect estimate that lets us move towards some kind of policy intervention or understanding. Okay, so now that we have some questions, we want to try to answer them. And so, overall, what do we want to know? We want to know, how would the world have been how would things have changed if the world was slightly different? So, in an ideal world, we have a time machine. We do take some action. We go forward and measure what happens. We hop in our TARDIS, go back, do the same action again, see what happens, and then we choose whichever is the best, has the best set of outcomes. Obviously, in reality, we don't have a time machine yet, or maybe ever, because if no one's shown up with a time machine, maybe we just don't have a time machine. So instead, we could do a randomized trial. And so now we're assigning people to treatment A versus treatment B in some randomized way that balances their expected counterfactuals and creates independence of those counterfactuals from the treatment strategy. But again, many decisions need to be made now. Randomized trials maybe could answer them, but we don't always have randomized trials, and waiting for a randomized trial to be done in the future is not an option. We can't just say, we'll keep doing what we're doing now until we get more information. That's a decision to follow the status quo and not making a decision. And then in reality, even a perfect randomized trial is really hard. Lots of our randomized trials are imperfect and prone to many of these same biases. So luckily we have a solution that's old as Epi, and I have, this is just a cartoon of grumpy old stats dude just for fun. I have already mentioned that solution is the target trial framework, and calling it the target trial framework is a new thing, but you can go back into some of the earliest Epi articles and read people suggesting that we think about designing our studies as if we were designing an experiment. And that's really all the target trial framework is. So instead of doing a randomized trial or instead of a time machine, we're going to emulate what would have happened if we could have done a perfect randomized trial. And this helps us avoid biases that could arise from informative censoring, non-random non-adherence, competing events, poorly defined causal questions, generalizability and transportability issues, and incorrect interpretations, even when the thing that we're using to emulate a perfect trial is randomized trial data to begin with. So the target trial framework can actually be applied also to randomized trials and can help us make those trials better. So what might it look like? Here's an example of a target trial framework where we have a list of the protocol components and a description of what those components would be in our ideal randomized trial. I'm not going to go through this, but just here in case people want to come back to it. But you can see we sort of think about all of those steps from what the trial would be. One of them I want to highlight is the idea of the causal contrast of interest, because this is something where I think we don't necessarily talk about why those might be different sometimes. So the target trial framework can help us identify our causal estimand, which is our target parameter, or our causal contrast of interest. And these really fall into two general schemes. We can have intention to treat effects, which tell us about the effect of randomization to treatment or assignment to treatment. Sometimes people will consider the effect of prescription of a medication an intention to treat effect. So this is the idea of you're estimating the effect of hoping that someone will do something or telling someone to do something. And then we have the category of effects called per protocol effects, which are really just treatment effects. So the effect of initiating a treatment, the effect of adhering to some treatment protocol over time or exposure history over time, or the effect of a point intervention among compliers, which is the IV estimate that I'm not going to go into. So why is it important to kind of think about these? Well, first, the intention to treat effects are generally only really available in randomized trials. In every other scenario, we're typically not estimating an effect of randomization, although you can kind of make an argument sometimes for prescription or something similar like that, where you're not necessarily actually telling the person or giving the person the treatment. On the other hand, maybe making the prescription is the exposure you're interested in. Per protocol effects, on the other hand, are available in both randomized trials and observational studies. And this is important because it helps us think about how we should be comparing data from different sources. And comparing data from different sources is a big part of how we decide what actions we are actually going to take. So here's an example of a comparison between randomized trials and observational studies that doesn't necessarily consider the estimand and potentially comes to the wrong conclusion before that. So we're looking here at a comparison of randomized trials and observational studies that are supposedly answering the same clinical question. The conclusion of this paper was that studies from observational studies were substantially overestimating, systematically overestimating treatment effects relative to randomized trials. The problem is that if we think about this in the target trial framework, the randomized trials are estimating the intention to treat effect. The observational studies are estimating the per protocol effect. And something we know about these effects is, when the comparison is placebo, the per protocol effect is the true effect of treatment, and the intention to treat effect is biased towards the null if there's any non-adherence. So is it really fair to say that the observational studies are overestimating the effect if the effect that they're estimating is expected to be systematically further from the null than the effect that the randomized trials are estimating, given that we expect at least some adherence in every non-adherence in every trial? And so thinking about what specifically is the estimand can help us reconcile the difference between these different types of studies. Okay, so then if we don't have a trial, next thing we want to do is emulate with observational data. And this is what probably most of us spend most of our time doing in Epi, but as I'm sure you all know, it is hard. So some of the really big challenges are, who should we include in our study? When does baseline start? And why did exposure happen or not happen? And so that's really about, generalizability, time zero and immortal time biases, selection biases, and then confounding. And so in the context of observational studies, we end up with these biases which tend to be more common or potentially unique in observational studies versus trials. And that's baseline confounding. So in a trial, you can have post-baseline confounding, but you don't have baseline confounding. Time zero or immortal time bias. In a trial, again, time zero is always the time of randomization, so it's really clear. But in an observational study, especially if you're comparing something like treat versus don't treat, when does, I always like to say, when does never start? If we're trying to understand who the people are who are never treated, how do we know when they start? Never. Structural positivity violations. So a positivity violation happens when a type of people in your study just cannot get one or the other of the exposures. In a randomized trial, this shouldn't be possible because we have specified the probability of exposure for each person in the trial based on what our randomization variable is. But in an observational study, it can absolutely happen. And then ill-defined causal questions can happen somewhat in a randomized trial, but are much more common in observational studies. And the target trial framework addresses these by forcing us to be really explicit about when baseline is, forcing us to be really explicit about who our target population is and what our inclusion-exclusion criteria are, forcing us to be explicit about the interventions that we would compare if we were conducting a hypothetical trial, clarifying the causal question and the causal estimand as the contrast that we would like to get from the trial and how the per protocol effect might differ from the intention to treat effect. So this kind of reiterates that this will help us make better questions. So once we set up our target trial, the next thing we're going to do is analyze it. And the second piece of the target trial solution is typically to use G-methods to actually analyze that trial. The G-methods are mostly parametric G formula, inverse probability weighting, G estimation. Also on this second slide, I've added in doubly robust, which I always forget about because I don't really use it myself much, but it's a good one to know. And if we're thinking about machine learning, then we can also call this TMLE. So I want to talk a little bit about what these are and when you might want to use them. So inverse probability weighting of marginal structural models, parametric G formula, G estimation of structural nested models, and doubly robust estimation. Okay, so the G in G-methods, it basically stands for generalize. So the G-methods generalize the estimation of our causal effects to settings that have potentially treatment confounder feedback over time. And we can think about this set of G-methods as roughly equivalent to other methods that we're more familiar with in a non-feedback setting. So if we think about inverse probability weighting, that is roughly similar to propensity score. The inverse probability weight is 1 over the propensity score if you're exposed, and 1 over 1 minus the propensity score if you're not exposed. The parametric G formula is basically a generalization of standardization, and G estimation is sort of equivalent to instrumental variables in that instrumental variables are a specific subcase of G estimation under some strong constraints. So what this means is when you have treatment confounder feedback, you could choose either inverse probability weighting, the G formula, or G estimation in scenarios where you would normally use propensity scores, standardization, or instrumental variables. Doubly robust estimation kind of combines the benefits of both inverse probability weighting and the G formula, and so you could use it in either the propensity score or standardization setting. So one of the things I like about inverse probability weights and why I often choose it is when I have a lot of different types of missing information. So inverse probability weighting is a way of correcting for missing information. And part of that is missing information in the counterfactuals that we don't observe, but also missing information in loss to follow-up. So if we're missing outcome for some individuals, missing information in adherence. So if some people didn't adhere, then we don't observe a counterfactual we expected to observe from them. So that's missing information. And then other kinds of missingness, for example, if people intermittently skip visits, we can build weights for that. And so I like using inverse probability weighting when I think I have distinct types of missingness that I want to correct for, and I can combine those all together and get one correction tool. The parametric G formula, I'm going to talk about that a little bit more. So this is, again, a generalization of standardization to time varying settings. The formula part is an equation that relates the observational data to the counterfactual data. And then when we talk about the parametric G formula, we're really meaning the method of solving that formula via Monte Carlo simulation, which uses and relies upon parametric modeling assumptions. So the general formula for the G formula, if we have a single time point of exposure, this basically boils down to standardizing the observed outcome within joint strata of our covariates and our exposure, standardizing that across the distribution of our confounders. And if we've chosen the correct set of confounders, this should estimate the counterfactual outcome probability for a given exposure status. When we think about time varying treatment confounder feedback or multiple time point settings, what we see is that although the equation gets a lot more complicated, it still has those same basic pieces. So a stratum specific observed outcome measurement where the strata are defined by exposure history and confounder history, as well as some distribution of those confounder histories. And then this lets us estimate now not the single not the single counterfactual outcome probability at one time, but the counterfactual outcome distribution as it evolves over time. So the G formula has historically been solved with Monte Carlo simulation, but if we have a very small number of covariates or time points, or if we have a single time point, we can just calculate that by hand. We don't necessarily even need to use a complicated way of solving it. But any kind of continuous covariate makes it impractical or impossible to calculate by hand. And often we have many covariates, many confounders, and many time points. So then we might use Monte Carlo simulation, and there are packages in SAS and R for that. Or we can use an iterative approach, and this has been more recently described by Dr. Lan Wen and colleagues in biometrics. Okay, so moving on to what happens if we don't even have the observational data that we want to have. And this has been a big challenge in COVID, right? We don't have a trial yet, that would take too long. We don't even have observational data yet, but we still have answers that we need to get because we have decisions that we need to take now. And so we might not have observational data because there's not enough data available, because existing treatments, because we want to know about how existing treatments would work in a new population we haven't studied. We might want to know about novel indications for existing treatments. And this is, the hydroxychloroquine and ivermectin situation. We might want to know about a hypothetical exposure or treatment. How good would a treatment have to be to address a particular health condition? And so the next question is, what else can we do? Well, we can still use the target trial framework, but now instead of emulating our target trial with a randomized trial or emulating it with an observational study, we can emulate it with simulation modeling. Simulation-based approaches give us much faster, much quicker decisions. They require much less data, and we can kind of think of them as a tool for combining everything we know, all the available data we have, and the expert best guesses that we need to make about things we don't know about into some sort of quantitative prediction of what the trial would have told us if we could have run the perfect trial. Now, not every simulation is going to work like this. Not every simulation is a target trial emulation, but I'm going to talk through how we can think about reframing our simulations to make them target trial emulations. So first, what categories of simulation models can we think about? So we have individual level simulation models and group level simulation models. In the group level category, we can have compartmental models, Markov cohort models, SIR models. These are all sort of structurally similar, but different subfields have different names for them. In the unit level model or individual level model, we can have just individual level simulation models, micro simulations, agent-based models. Sometimes we might do discrete event simulations. All of these ways of estimating for particular individuals what's happening rather than for groups. So I want to talk a little bit how these are different, because although these are group level and individual level models are structurally very different and implemented very different from a causal inference target trial emulation perspective, they're actually doing the same thing. They're just making different types of assumptions. So the key assumption for a group level model is that you can lump people together by certain characteristics, and that will take care of everything you need to know. So something like a susceptible, infected, recovered model lumps all the susceptible people together, all the infected people together, or all the recovered people together. If we want to then further make that a stratified model with 2 or 3 or 5 susceptible categories, we can do that, but we don't have to. And those decisions about what compartments to have depend on our assumptions about what things matter. The individual level or unit level models simulate people living different virtual lives. And now the assumptions are, what do those different lives look like? So we can think about the group level models from an epi target trial emulation perspective as really chiefly focusing on assumptions about effect modification. What types of people are sufficiently the same from the perspective of your causal question that you can lump them together? What information is necessary to track? Which information can be discarded? And which strata of the effect modifiers are important for coming to some kind of conclusion about your data? On the other hand, individual models, and you may recognize here your WBOB building, individual level models make assumptions about risk factors. So what types of people are in your population? What things affect their counterfactual outcomes? What types of things determine who comes in contact with whom? What determines who gets sick or who gets exposed? What determines how long until someone recovers or dies? So we're thinking about covariates and confounders in the individual level model more than effect modifiers per se. I like to think of individual level simulation models as kind of a layer cake. So we have maybe an individual life history layer, and then we can also add on things like environmental exposures as a layer, contact patterns as a layer. And each layer that we have has its own assumptions about, what things are important for that layer. What layers we choose to build onto our layer cake are an important subset of our assumptions. And then also how information flows between the layers is another important set of assumptions. And so altogether, those make up the structure assumptions of our model. But as I said, if we don't just want to build a model, we want to build a model that makes decisions that will help us in the real world. And so in that case, we need our model to replicate the real world under real world scenarios, and then also replicate what would happen in the real world if we did something different in the real world. Let me skip that. So this basically gives us a trade-off between assumptions and data. Simulation models require less data. They require more assumptions, but they let us make a broader set of causal inferences about a lot of things, because we can just include more assumptions to get more questions answered in our model. On the other hand, when we're emulating with an observational study or a randomized trial, we need more data, but we are rewarded for our more data by making fewer assumptions, and then we get typically one clear causal inference answer in one population. Okay, so I want to talk briefly about the types of assumptions that we need for causal inference. And so because those are true for all of our target trial emulations, including simulation models, and hopefully these are sort of familiar to you all, so I'm going to go through it fairly quickly. But we need assumptions around the exchangeability of our counterfactuals, so the independence of our counterfactuals from the observed exposure, either unconditionally or conditional on covariates. And what that boils down to is no unmeasured confounding. So all common causes of our exposure and outcome are known and measured in the data, and no open colliders, i.e. all common effects or their consequences of treatment and the outcome are known and not conditioned on in the data or the analysis. And that second one is much trickier and often is the one that trips people up. We also need to have positivity. So we talked about this briefly before, but basically the idea that all levels of treatment are a possible option for all types of individuals that matter in our study. So for all our confounder strata, everyone in those strata has a non-zero probability of every level of treatment or exposure that we're interested in. We need consistency, which is just another way of saying we need those really good causal questions. And then when we think about emulating target trials using simulation models, we need to add some additional assumptions, because we said there's a trade-off. We use less data, but we have to have more assumptions. And one part of those additional assumptions is that in an observational or a randomized trial emulation of our target trial, we only need the assumptions to hold for our causal effect that we're estimating. So for our treatment or exposure and outcome, that's the piece that we need to have unbiased. In a simulation model, if we want that simulation model to return to us answers about the real world, then those assumptions I just talked about have to hold for every single pair of variables in our simulation model. And that starts to get really tricky. And one of the particular ways it gets tricky is that our simulation models often include mediation. And the mediators in those models are very often biological mechanisms or other types of mechanisms that we can't directly intervene on. And this is tricky because now we need, in the observational study, we only need a well-defined causal question for the exposure if we're just estimating the average treatment effect. But in the simulation model, we also need a well-defined causal question for the mediator. And this gets back to that idea of, now are we estimating the waste? In the simulation model, that might get very confusing, because who even is the population that we're estimating it in? What is their distribution of ways of having an intervention? And this can get really tricky to parameterize really quickly. A couple of the things to think about that make a simulation model different than an observational study where you're trying to estimate a mediation effect is that in a simulation model, you need to think about, well, if your mediator is a continuous variable, for example, some immune function variable, and you have to parameterize a controlled direct effect of your exposure on the outcome, holding that mediator fixed at some value, how is it getting fixed? And also, what value are you choosing? Are there 1,000 different controlled direct effects for 1,000 different values of that mediator? Or is any value you hold the mediator at, does that give you the same controlled direct effect? Or maybe there's a step function in the controlled direct effects and the values you could hold the mediator at. And because those controlled direct effects themselves are so hard to estimate, it's really hard to get intuition and understanding and expert knowledge about how to parameterize those. And then the last assumption we need for simulation emulation of target trials is that the parameters themselves also have to be externally valid. And this is important when we're using more than one data source to parameterize our simulation model. And basically what it boils down to is that in addition to no unmeasured confounding and no open colliders and positivity and consistency, and that for all of the variables in our model, we also need all of the possible outcome causes for every variable in our model that looks like an outcome to either be known and included in the model or identically distributed between all of the populations that we're getting data from and the populations we want to make inference about. And that starts to hugely blow up. I'm not going to show the results here, but we did a number of sort of studies looking at how this might work in theory or how this might work in practice. And the bottom line is we can turn our assumptions into knowledge and causal effect estimates that seem reliable and valid using simulation-based approaches to target trial emulation, but only if all of our assumptions are correct. Unfortunately, even in the simplest case, it's hard to get the assumptions correct. Even if we get them correct, we never know for sure that we got them correct. And when we add in transmission, things get even harder. And so this is something that's made COVID even more difficult than all the hard things we already do in Epi. So I want to very, very briefly in the last couple minutes talk about how transmission makes things harder. So the easiest kind of model to start with is one where individuals don't interact with each other. They don't have any agency. They have no environment or neighborhood effects that are shared between them. And this is what most of our causal inference tools focus on. But the target trial framework can help us relax some of those assumptions in a clear and systematic way to get an answer that we could understand. So in a simulation model of a transmission situation, we want to know something about how, not just how is the exposure affecting an individual or how is the treatment affecting the individual, but how is that affecting the way that infection propagates through a network. And this can be really tricky to understand because it depends on the characteristics of the network. So the big problem is that typically when we do causal inference, we make an assumption that just interference doesn't exist. But in randomized trials, we do have some solutions that let us relax this assumption. And those solutions are things like cluster randomized trials, two-stage randomized trials, ring vaccine trials, and other sort of similar interference-friendly trial designs. So this is the type of design we need to think about emulating when we do simulation models of infectious diseases where we're trying to answer causal effects. And I'm not going to go into detail of what those effects are that we can estimate in these trials, but to say that this is not the average treatment effect that we're estimating. We might estimate a disseminated effect. We might estimate a composite effect. We might estimate an overall effect, but those are different than the average treatment effect because they take into account not just what happens for you, but what happens for those people around you. And so we can use these trial designs to, as our target, and then emulate them with our simulation models and get much clearer answers. And so this is something I've been working on with collaborators at Brown and the University of Rhode Island, thinking about how do we emulate a target trial of PrEP distribution in a sexual network in order to understand both those individual benefits and those community level benefits to PrEP usage in reducing HIV infection. And what we see is that we get a number of different answers to these questions because it depends not just how many people are we giving the intervention to, but it depends on who's in the network. It depends on how those networks might change over time. It depends on what the prevalence of HIV is in that network to begin with and how that evolves over time, as well as, you know, who actually is taking those interventions. And sometimes even which of the people are randomized to an intervention instead of just the percentage of people. So these questions get much more specific and we have to think much more carefully about how to interpret them. Okay, so I want to just do a quick summary of everything I talked about, coming back to our two-step method for causal inference. So the first step is asking a good causal question. And as we've seen, this is really hard, but the clearer we are about asking it, the easier it is to make use of the answer and the more valuable that answer is for helping to improve public health, which is our sort of ultimate goal. And then the second question is, how do we answer those? You know, the second piece of our two-stage is to answer them. We saw that is also really hard. We have on one end of a spectrum, some really ideal randomized controlled trial or experiment that we would like to do that is perfectly unbalanced, that we're going to think about for our target trial. On the other end of our spectrum, we have gut feeling, which is probably intractably biased, and then all the different study designs we can use to emulate our target trial kind of fall in various places along this spectrum. So a nice, well-done explanatory randomized trial could still suffer from a lack of generalizability, could still suffer from loss to follow-up. Those trials, as well as pragmatic randomized trials, could also suffer from non-adherence. Observational studies, now we add in baseline confounding, and simulation studies, now we have this problem of all of these assumptions, and that gives us a really ill-defined uncertainty estimate. And so there are all these different problems that kind of crop up across the spectrum of potential biases, and no study design is immune to bias. They all have their particular pieces of that are more important. So with that, you know, ask good questions, answer them appropriately. It's definitely easier said than done, but that is the takeaway message. So I'm going to end here, and I'm kind of impressed by myself that I fit this into an hour because I thought it was too many slides. But I'm happy to take any kind of questions that anyone has.
Thank you, Ellie. That was excellent. Given the time, I'd like to invite anyone with a question to ask a question now. If you could use the raise hand function, we would appreciate it. Maybe we can ask that people who must leave right away, we'll prioritize those questions.
It looks like Caletzo has a question.
Hi, is that okay? Let me ask it. Hi, thank you for the presentation. Mine is more of a comment than a question, and I know that's the most annoying thing to hear. It is actually a question about what I think is an implicit assumption in the target trial framework and how that might change our interpretation. So I think, or actually maybe the question is, how does this make sense? So I think like one of the assumptions is that you're not dealing with a zero-sum game. And when you are dealing with a zero-sum game, then it doesn't. Okay, let me give this example. So if you have the example of COVID, if you're trying to estimate the mortality of the counterfactual mortality of Black people, had they experienced the same mortality as white people, and you're using the experience of white people to make that estimate, then you're assuming that the mortality of white people is not related, diametrically opposite to that of Black people, which in the case of COVID is not true, because we know that the industries that kind of we depend on to produce food and transport and all that have disproportionately Black people represented there. So if we were all to get, so I don't think it's possible that we would all have the same mortality as white people, because the mortality of white people is low because that risk has been transferred to Black people. So I want to put that out there and ask whether it makes sense and how it would change kind of the interpretation of the estimates we get from the target trial framework.
Yeah, so I think that's a good question. And this kind of shows that the kind of highlights the sort of fuzziness between the average treatment effect and the weighted average causal effect, because, basically part of what you're saying is that, there are a lot of things that factor into whether somebody is going to die from COVID. And we're kind of averaging over those and saying, we're kind of assuming that the distribution of those reasons someone dies from COVID, that we could just transfer that distribution from white people to Black people, and that would kind of transfer their probability distribution of dying. And that is probably not that simple. And so, I don't think that the comparison I highlighted there gives us the definitive single answer, but it does move us closer than trying to say, like, what if all Black people were white, which doesn't really help us at all. The other thing I was going to say is that we can also think about more complicated trial situations where, for example, our goal is not necessarily to identify what is the optimal strategy for an individual under an unlimited resource setting, but what about if we have a set of resource constraints? So what if we can afford a maximum of 1 COVID test per person per month? What is the optimal way to choose who's getting COVID tests, so that in the end, we're not spending more money than an average of 1 test per person per month? And so we can kind of think about that in sort of the nice simple context, but we can also build it in as a layer in our simulation models, where people basically have to kind of compete for resources in our environment. And so basically the idea would be that we construct our environment to think about, what are the roles people play in society and what are the types of influences that have on them, and then take that framework and say, okay, here's the intervention we'd like to apply. Given all of that stuff, what if we could change the mortality risk? Conditional on infection and conditional on your occupation and all of these things. Is that something that even differs once we get down to all of those strata? And if it does, what happens when we change it? And then we can think about, if that makes a big enough difference versus instituting workplace safety guidelines that improve for a whole occupation or something. How do we actually go about doing that is like a next question. Does that make sense?
Yes, sorry. Thank you.
Ellie, let me say a formal goodbye before you can take Bert's question. Again, we're moving into an informal, unstructured time with Ellie, so you are all welcome to stay. But Ellie, we look forward to the day where you are able to visit us in person. So we very much appreciate your time and effort today. Bert.
Hello, friend. So I do agent-based model, I told you before, and there's a saying by Dr. Joshua Epstein that he said, if you don't grow it, you don't know. And that's kind of like tell me that agent-based model has a component of you making it happen to a certain level. So like when I use my agent-based model to answer any research question, I try to avoid using the term causal inference, but using the term, I explain the extent to which changing X caused the change of Y. In because I sort of have a feeling that I actually make it happen. So it's not really, in my head, it's not causal inference-ish, but epidemiologists tend to use the term causal inference, and there's a lot of writing about that, which I'm kind of like iffy about. So what's your thought on that?
Yeah, so I think this is a good question because basically every simulation model, if you make the model and then you change something and you run a new model, those are counterfactuals. And if you compare them, it's a counterfactual comparison. But it's possible that those counterfactuals are never ones that could ever happen in our world, right? And so, you know, that's sort of like, well, I made this model, you know, I had like an algorithm draw a cartoon of me and then I tweaked the shade and it was like more purple, right? Those are counterfactual comparisons in terms of what you do with that shade slider. But it's not a causal effect in the real world. And so, but often we want to use our simulation, and not always. So there are many other reasons we could use a simulation model, but when we want to use a simulation model to inform decision-making in the real world, then we have to try to target a causal effect that could be observed in the real world. So we have to try to figure out, how do we use our model to estimate the counterfactual outcome that would happen in the real world if we did A, and the counterfactual outcome that would happen in the real world if we did B. And so for that, I would say that's an attempt to estimate the causal effect. It's the attempt to emulate the causal effect you would have gotten from a target trial. I'm not going to say in my results like the causal effect is blah, but I am going to talk about the idea that I'm trying to get some information about that causal effect. But I think because every simulation compares counterfactuals, there's definitely like too lenient a use of counterfactual comparisons where people aren't really thinking about the fact that their counterfactuals don't reflect something in the real world. And I often see people making, you know, causal conclusions about differences in their model that change when they change a parameter, but that are entirely predictable from just looking at the value of that parameter and how they built their model. Like they haven't learned anything by running the model. They've just put that assumption in and gotten that assumption out at the end. And so that's like definitely a problem too. So, I mean, I think it's good to be cautious in how you explain these. Simulation models come with a whole host more assumptions and more uncertainty. But I also think it's good to be clear that when we want to be targeting a causal effect estimate that would let us make a decision if we got it right. And then we can talk about all the assumptions we had to make and how much we believe them or not.
Thank you.
Also good to see you.
So we have moved into our informal and unstructured time. I don't see any questions right now, but if there are, please do, again, feel free to chime in or raise your hand. Ellie, I'm wondering, there are some parts of the presentation that I think due to time constraints you rushed through. I'm wondering if there's anything that you'd like us to go back to and revisit in a more informal way.